finalists. I would like also to congratulate you that you made it to the finals. I'm only introducing the first case because, as Dr. Sofian Joha pointed out, the first case is from his own department, so he has to refrain from being involved in the first case. So I take the prerogative of, once again, as I did before, introducing Dr. So Min Maung from Myanmar, talking about iatrogenic neuropericardium. We have 3 minutes to present your case, and then we will ask you for about 5 minutes questions. So please go ahead.
It's a 36-year-old male who has presented to our lab with for the outpatient appointment for the echocardiography. Background of hypertension, hyperlipid diabetes, complicated with diabetic retinopathy and ESKD. He's already on peritoneal dialysis for last 3 years. So on further questioning, he got the shortness of breath on exertion that wasn't over a period of a month. And then he also noted to have low blood pressure during when he has the peritoneal dialysis at home. And this affects this echocardiogram of this patient of apical four-chamber view, showing that large pericardial effusion. Initial vital signs all are normal, except like mildly raised of JVP. On ECG, there is like low sinus tachycardia with low QRS voltage that was noted on the pericardial leads. On the chest X-ray was done on admission, showing of cardiomegaly. So echo findings are EF normal, large pericardial effusion as such, and also there is no tamponade features on the echocardiogram. So it's further diagnosis, further step. He was admitted, monitor for like around 1 to 2 days, monitor for 1 day, and then next day we have informed the nephrology team to adjust the peritoneal dialysis regimen, and then also that but next day we have performed the pericardiocentesis in view of further diagnostic purpose and therapeutic purpose. So pericardiocentesis was done, and then around 800 ml of pericardial fluid was drained. Fluid was sent for cytology, biochemistry, and tuberculosis screening. And fluid cytology showing of like inflammatory yield, large hemorrhagic pericardial fluid was drained out. So after the post-procedure, post-pericardial synthesis, chest X-ray was performed after 3 hours and showing that there is a pneumopericardium. So that pneumopericardium was aspirated around like a total of around 200 ml. And then after that, the chest X-ray was taken on the next day. So the chest X-ray taken was taken on the next day, show of resolution of the pneumopericardium. So on our case, the before discharge patient was the peritoneal dialysis regimen was optimized, and he has a repeat echo in around 1 month, and also we'll have the follow-up appointment for tracing the tuberculosis culture in like around 2 months period of time. For the landing point, for every pericardial effusion, the large cardiac tamponade has to be ruled out in this patient, although there is no tamponade features both clinically and echocardiographically. But according to the ESC working group for the echocardiography, the evidence of cardiotamponade trial system, he has a step score of around 5. And then this pneumopericardium was this one, and unfortunate complication after the pericardiocentesis. Although it doesn't happen any hemodynamic instability during the stay, but it can progress to the tension pneumopericardium eventually and can cause tamponade. In our case, what happened to the patient was there is accidental opening of the three-way stopcock on the connector, so the pneumopericardium was happen. And then if in case we emphasize mostly on the nursing care post-procedure may prevent such incidents.
Okay, congratulations, Dr. Maung, for this excellent presentation. I have a couple of questions that I'd like to ask you with regards to this case. You mentioned this gentleman is a 36-year-old with a renal problem. Has he had similar presentation with pericardial effusion before? And you quite rightly mentioned the guidelines suggest to undertake a pericardiocentesis in the setting of a tamponade or moderate effusion that's causing problem. From your presentation, I couldn't really work out the actual indication for effusion other than the echocardiographic presentation. Was this patient very symptomatic? And what do you think is the cause for his effusion?
The cause of his pericardial effusion should be this one because he has noticed that his peritoneal dialysis regimen was changed like around 2 to 3 months ago, and then his shortness of breath started to happen after like changing the peritoneal dialysis regimen, and then he has having like shortness of breath on exertion over a period of a month period. But on arrival to our setting, the blood pressure although the blood pressure vital signs are still stable, but his blood pressure tends to be on the lower side, like around 100-ish, plus like diastolics of around like 50 to 60, with systolic around 100. And also because the area here is more of like we are prone to have those of like any infective causes like tuberculosis. So we doing the pericardiocentesis not only for the therapeutic purpose but also for the investigation purpose. Although we think this pericardial effusion may be related to his long-standing the end-stage renal disease from the diabetes.
Okay, thank you. I will now pass on to my co-judges for their questions.
So, thank you very much. A very interesting case. As Dr. Konadan already asked you, right? There are some echo findings. How to identify the cardiac tamponade by echocardiography? How do you decide? We have to do the emergency pericardiocentesis by the findings of echo.
So on the echo finding, if in case there is a chamber collapse, septal bounce, or if there's like large circumferential pericardial effusion of more than 2 centimeter, and also like for the IVC assessments, if there is collapsibility of the IVC, and also like collapse of the cardiac chamber, especially RV and RA during the diastolic.
Yeah. By echocardiography, I clearly identify the collapse of right atrium, but I could not find the right ventricular collapse. What is the best way to identify the right ventricular collapse by echocardiography?
What is the best way?
How about the use of M-mode if you try to M-mode recording, if you try to identify the timing and...
It's mean during the respiratory phases?
No, I just mean the collapse in RV should be early diastole, right? So it is important to identify the timing of the collapse. Yeah.
Yes, thank you.
Okay, yeah, but a very interesting case, and you just run try to concentrate the stopcock condition, right? But after you treat the pneumopericardium, but you can still insert the catheter in the pericardium if you succeed to take out the air in the pericardium, because there are some risk of effusion increase even after air suction, right? Yeah.
I would also like to ask a question, just if I may, about the mechanism. I would think that the pressure in the pericardium is usually slightly positive. And how does the air get in there? Is it the deep inspiration that the patient might have done? Is it dehydration? Is there usually negative pressure in the pericardial space that will suck in the air?
It's unlikely, but on the chest X-ray, we have noticed one more thing is like the pericardial drain is a little bit higher, and then it's not in the pericardial fluid.
Yeah, it's not in the pericardial fluid because it's in the air. So there must have been some kind of venting mechanism or something that sucked in the air in this case, right? Because it's, to me at least, it would be unusual that so much air gets in the pericardial space. I would think it's unusual, but this is a very nice case. And I think in this case, we only have 3 questioners. So this concludes your very nice presentations. Congratulations already from all of us for the presentation. And we will move on to the next. And I think Dr. Johar can introduce the next contestant, please.
Yes, thank you very much. So the next contestant is Panupong Potter from Chiang Mai in Thailand. His case is about aneurysm ruptures associated with IgG4-related disease. So look forward to your presentation. Please go ahead, Dr. Potter.
Good evening, everyone. My name is Dr. Panupong Potter from Chiang Mai University. I'm pleased to be here to talk about the interesting case today. A 65-year-old man come with a chest pain and hypotension. Oh, sorry, okay. Chest pain and hypotension at first seen at the emergency department. For past history in 2011, he was diagnosed with IgG4-related disease from the high serum IgG level, the histopathology from the RCA aneurysm, and history of multiple arterial aneurysm as shown as a timeline. The immunosuppressive agents were prescribed accordingly to the rheumatologist after the diagnosis. In this time, the initial diagnosis in this case, the 12-lead ECG showed the T-wave inversion at the inferior lead. The chest X-ray showed the soft tissue mass at the left heart border, like this, and the echocardiogram showed the hemopericardium decompressed at RV free wall and still seen at the posterior wall too. From the initial workup with a history of the RCA aneurysm before, we suspect the coronary artery rupture, and we send patient to the cath lab and do the coronary angiogram, and you will see the aneurysmal change at LAD, and you see aneurysmal change at the OM2, and we see the active contrast extravasation. The coronary artery the coronary artery rupture is the simultaneous coronary artery rupture was the diagnosis after that. We consult the surgeon emergently after that, and patient was sent to the operative room. For the intraoperative finding, we found that LAD aneurysm is rupture, and the second OM is a concealed rupture because the surgeon don't see active bleeding sites. The management in this case, the surgeon decided to repair the LAD aneurysm with the bovine pericardium, and the upper the sac with the glue. The CABG was done too after that. For follow-up this patient will follow with the multidisciplinary team. We interval CCTA and whole aorta next to months as shown as a picture below. We found that the patient have the rapid growing of the LAD aneurysm despite the aneurysmal repair. We suspect maybe from the rapid progressive and actively disease from IgG. And we also schedule CCTA next 6 months too. For the learning point in this patient, the IgG4-related disease is the one of differential diagnosis in patient with multiple sites of arterial aneurysms. The coronary artery rupture in the IgG4 is extremely rare condition, but we need to be concerned in patient came with a chest pain or the ACS equivalent. For a non-invasive interval CT may be important in this patient to assess the progression of aneurysm due to the lack of biomarker data to relate it to disease activity. Thank you.
Thank you very much.
Sorry, Dr. Potter, that was a fantastic presentation. An interesting case. But I just have a couple of questions. One would be how common. Two is there any possibility you could have treated the aneurysms with a covered stent rather than going to surgery?
Pardon, this connection is disrupt.
I will just ask you: is IgG4 disease common in Thailand, and could you have used a covered stent?
No, it's not common in Thailand. It's the almost report is happened in Japan. The Thailand is no report incidents or prevalent now.
And could you have used a covered stent to treat the aneurysms?
And after we discussed with the team, I mean the cath lab team, my professor think that the lesion is maybe bigger, and to use a cover stent or the glue, something of a in intervention procedure. And we did, and after meeting with a surgeon, I think in this situation, we think the surgery is maybe the best way in this time to correct in cause in this patient.
Okay, thank you. I'll ask the rest of the jury to comment if they have any questions.
Yeah, thank you.
Okay, thank you very much, Dr. Porter, for an excellent case. I do have a few questions. So just to understand, this patient has renal aneurysms as well, yeah?
Yes.
Did he have cerebral aneurysm? That's one of my questions. And with regards to the entire coronary situation, you mentioned that maybe in 2019 or sometime back, he might have had a bypass surgery.
Yeah.
Yeah. So, did the surgeons not consider fixing all of these aneurysm in one go back then? What was the thoughts behind not dealing with LAD at the time?
Okay. From the first question, you asked me about the cerebral aneurysm. The patient didn't CT brain before, and he not have even about the neurologic symptom before. But we think we have to find after this time, after that. And the second about the how to you asked about the LAD aneurysm after this. What we should do, right?
No, my question was, from reading through your case, it sounds like the patient had bypass before September 2020, before the current presentation.
But you mean CABG, right? The CABG, right?
Yes.
Okay, and patient was performed was CABG in the 2011, but they do only the just right side, the right coronary artery, but left side is fine. There's no lesion at this time.
Okay, so this aneurysm has actually grown or progressed since his last bypass surgery.
Yeah, it's progression. Yeah.
So during the follow-up, you mentioned that the aneurysm has recurred.
Yeah, we suspect it might be from the rapid progressive. We set up the multidisciplinary team to discuss with how to prevent rupture in the future. I'm not sure about the aggressive immunosuppressive agent or using some intervention procedure or elective surgery again.
Yeah. So you mentioned that the patient had a bypass put into his LAD. So perhaps because the aneurysm is proximal, the surgeon might consider ligating the whole aneurysm as such to prevent another progression of aneurysm and rupture afterwards. Was that considered during a multidisciplinary team meeting?
The multidisciplinary team was set soon. It's not set. It's not set, but because the follow-up CT had just done just a few days, just a couple of days.
Okay, thank you.
We're not sure about the result from the surgeon.
Okay, thank you. I will now pass on to my co-judges.
Thank you very much. Very interesting case, and yes, IgG4 related this kind of aneurysm is very rare, and the treatment is very difficult. And in this case, you had CABG previously before rupture.
Yes.
I think it was very lucky, because if there are no adhesion of the pericardium to the attached to the myocardium, after rupture there are a risk of tamponade, right? But in this case, very lucky. Are there any discussion about such condition?
Pardon?
In the heart team, did you have such kind of discussion? You
mean in this case?
Right. Yeah.
Okay.
Yeah.
We start discussion between the procedure, the intervention to treat this patient to save his life. We start with us. We talked to the cath lab team first, because we need the intervention. We choose the intervention first, but our team think that it's not compatible with this patient. Then we decide to surgery after that.
Okay. Very, very short question. I'm sorry, because of time limitation. This is a general disease, not only focus on the coronary artery. How to treat this condition after you succeed to treat, right? Yeah.
Okay. From the evidence until now, we have no the RCT treatment in this disease, but from the case theory or the report, we consider that the glucocorticoid or like a prednisolone is a first line of treatment. And some cases we use the steroid sparing agent like rituximab or methotrexate or azathioprine. Okay, but we don't know what as I reviewed the literature. And as the non-vascular manifestation is some improved, but in the vascular complication is we don't know the result.
Okay, thank you very much.
Thank you very much.
Next case will be Dr. Senthil Sami, who will talk about embolization of a high output idiopathic renal arteriovenous fistula using a vascular plug. Please go ahead.
Good evening. Thanks for the wonderful opportunity. My case is an embolization of high output idiopathic renal arteriovenous fistula, primarily using a vascular plug. So it's not, my patient is a 65-year-old female who presented with progressive dyspnea, easy fatigability, bilateral pedal edema for the past 2 years. She had a past history of hypertension for the past 6 years and was on antihypertensives. Her general examination, she had a bilateral pitting pedal edema, a raised JVP, and a raised blood pressure, which was 160/90 in spine. And pulse pressure rate was about 1 or 2 per minute. Auscultation, cardiac auscultation showed a loud first heart sound and a prominent third heart sound. Abdominal examination revealed a prominent bruise in her right lumbar region. So the patient was worked up with ECG, which showed sinus tachycardia. Chest X-rays revealed a mildly enlarged cardiothoracic ratio. And ultrasound revealed dilated vascular channels in the upper pole of the right kidney. A echocardiography was performed, which showed that there was a dilated right atrium, right ventricle, and a moderate tricuspid regurgitation and dilated pulsatile inferior vena cava with a continuous flow in the color wave Doppler. So we further proceeded with a CT angiography of the abdominal aorta, which showed that there was marked dilated tortuous renal artery, which was communicating with the renal vein, and a dilated IVC. In the arterial phase, you can see that there is a early opacification of the renal vein and a tortuous renal artery. So a DTPA renal scan was further performed to assess the functional status of the kidney, which showed that there was a moderate to severe reduced cortical tracer uptake in the upper pole of the right kidney, which was suggestive of a non-functional upper pole of the right kidney. And so we proceeded with the renal angiography, which is the gold standard to assess the renal arteries. There was an aneurysmal dilatation of the renal artery with rapid washout of contrast to the IVC, suggestive of idiopathic renal AV fistula. So we made a final diagnosis of idiopathic renal AV fistula, leading to a high output heart failure. So we decided to go with the endovascular approach to treat the AV fistula. We took a right common femoral arterial access. A 6 French introducer sheath was used, and the aneurysm was probed with a hydrophilic wire, and it was exchanged with an amplet stiff wire, and then the introducer sheath was exchanged for a 7 French long sheath. So after angiographic confirmation, and the narrowest part of the aneurysm was about 10 millimeters, so we used a vascular plug 2 device, which was 14 mm and deployed after angiographic confirmation. So the final iotogram revealed a successful embolization of the AV fistula, and echocardiography performed post-procedure showed that there is a regression in the tricuspid regurgitation, and a CT angiogram was repeated 3 days post-procedure, which showed that there was a device in situ, and there is a complete thrombosed aneurysm, and the fistula tract was completely thrombosed. The discharge was uneventful, and the patient was followed up in the outpatient with a good improvement in the functional status and the well-being. So the learning objectives in my patient is a proper clinical examination can help even identifying the rarest of the diseases. Renal atrial fistula type of AV malformations which are very rare and can have varied presentations from incidental detection to a symptomatic heart failure. The therapeutic aim is to retain the functional nephrons as much as possible. Percutaneous embolization techniques are the first-line management options, and vascular plugs are excellent options for accurate vascular occlusion and to prevent risk of migration. Thank you.
Dr. Thangasamy. I will now ask my fellow jury members if they have any questions to ask in this case.
Yes, thank you very much, Dr. Thangasamy, for your great presentation. My question is, looking at your post-embolization CT, the size of the kidney as such appears very small compared to the kidney on the unaffected side. Do you think that might have any, what is the reason due to that? Is that because the aneurysm has taken over quite a lot, that the size of the kidney has reduced, and what might be the implications for the future renal function of that patient? And my next question is, does the patient have similar aneurysm anywhere else? Have you looked elsewhere? And the third question, you mentioned idiopathic, and sometimes if we don't find an answer, we call it idiopathic. What test did you do to identify the potential reason why this patient might have had such a large aneurysm at the age of 65 before you decided it was idiopathic?
My answer to the first question is that we first investigated with the duplex ultrasonography, and both the right kidney and the left kidney sizes were not decreased, and there were dilated vascular channels which were compressing the kidney, and the DTPA renal scan which was performed before procedure showed that there was a non-functional upper pole of the kidney. So the kidney was not yet shrunken in first part. And so the lower pole of the right kidney was supplied by accessory renal artery, and it was functional. So the split renal function in DTP renal scan was about 38% in the right kidney and decreased 38% in the right kidney, and the left kidney was about 61%. So the split function of the right kidney was decreased. So we could preserve the lower post part of the renal right kidney, which was supplied by accessory renal artery. So we thought of embolizing the upper part with no clinical, without any further hemodynamic consequences. So the second question is, we didn't look for aneurysmal malformations other than abdomen. We looked for screening of aneurysms in abdomen, which was there was no other aneurysms in the abdomen. We thought the patient presented with heart failure, so we thought of medical stabilization and immediate treatment option, and we thought of doing an MRI brain to rule out any cerebral aneurysms in the later. And we labeled this as a idiopathic renal AV fistula because renal AV fistulas are very rare malformations. They are only about less than 0.04%, and they can be a congenital or idiopathic or acquired. Acquired is the more common, and most of them are traumatic. So in olden days, during Vietnam War and everything, there was most of the cases are traumatic. So traumatic aneurysms usually have the history of a penetrating or a blend trauma, or the patients can have some pseudoaneurysms which can be there. In congenital aneurysms, usually it will not be there. There can be multiple vascular network formations, which are typically in congenital AV malformations. But in our case, the angiographic appearance is a single arterial feeder and a single venous drainage, which is more towards idiopathic etiology. Still, it's as we couldn't find any etiology, we labeled as idiopathic renal arterial fistula.
Okay, thank you very much.
Okay, thank you very much. A very interesting case, and congratulations on the success of the treatment.
Thank you, sir.
So my question is, the patient, why the patient have the symptom at this moment? Are there any trigger to accelerate the symptom? Do you speculate?
So actually this idiopathic AV fistula is the can lead to a high output heart failure. Due to increased cardiac output and the fall in the systemic vascular resistance, the blood flow can increase to the renal vein and in turn to the IVC, which may the heart is overloaded. It can increase the workload of the heart. So, and the patient had on admission, she was on more than 3 antihypertensives, and still she had a BP of 160 by 90 millimeter of mercury. So she had a basal crepitations on admission. So this mostly of a heart failure presentation. The patient had a heart failure presentation.
Yeah. But this condition is not occurred suddenly, right? It is continuing, right?
Yes.
So are there any trigger to increase the symptom? Do you think that the increase of shunt ratio or something? I'm not sure. Just speculation, right?
No, sir. The patient was drug compliant. Maybe she had some anxiety or a sudden shoot up of hypertension, which would have caused a sudden deterioration in her function. Or a progressive renal function deterioration can cause a sudden symptom status. Actually, her creatinine EGFR was little reduced. It was around 70 ml per minute.
Very short question. Did you measure the shunt ratio when you treat the patient?
So no, sir, we didn't measure the shunt ratio. We measured the aneurysm size, which was around 47 mm, and any aneurysms which are more than 20 mm should be intervened.
Okay. Anyway, yeah, very interesting case. Thank you very much.
Thank you, sir.
Thank you. If there are no more...
One very quick question. How did you perform with antithrombotic or anticoagulation treatment after placing the occluder?
Yes. Actually, there is no recommendations of a proper treatment after atriovenous fistula embolization. So some prefer giving antiplatelets and anticoagulation post-procedure. But antiplatelets and anticoagulants, in some case reports, it has been mentioned that there has been no role for antiplatelets and anticoagulations. But in our patient, after post the embolization, the CT showed a renal vein thrombus. And so we started her on anticoagulation, oral anticoagulations post-operatively after the third day to prevent risk of pulmonary embolism.
Thank you.
Thank you, sir.
Okay, thank you. Thank you. I think we need to move on to the last case. So the last case is by John Lee from Melbourne, Australia. He's going to talk about pyeoneuropericarditis manifesting as a novel murmur. The case report.
John, I'm a cardiology resident from Monash Heart in Melbourne, Australia, and I'm excited to present the case of pyeoneuropericarditis presenting as a novel murmur. We had a 49-year-old gentleman who was transferred to our tertiary centre with one-day history of sharp central chest pain that was relieved by sitting forward and worsened when lying down flat. This was associated with diaphoresis, vomiting, and fever. His past history demonstrated an uncomplicated Roux-en-Y gastric bypass surgery in 2013, psoriatic arthritis well controlled on leflunomide, type 2 diabetes mellitus controlled on metformin only, and hypercholesterolemia on simvastatin. What was unique was that on examination, the patient had a continuous murmur that was audible throughout the precordium. In the apex, you could hear a succussion splash, whereas in the left upper sternal edge, you could hear a pericardial rub and mediastinal crunch. So the initial workup was on his admission ECG demonstrated features of pericarditis with 1 millimeter PI interval depression in leads 2, 3, and ABF, and reciprocal elevation in ABR. His chest X-ray demonstrated pneumopericardium and enlargement of the pericardial silhouette. In his CT scan on the left, on the sagittal view, the white arrowhead demonstrates the gastropericardial fistula. And on the right, on the axial view, the yellow arrowheads demonstrate the gas, and the red arrowhead demonstrates the locule of the pericardial effusion. The patient was taken emergently to the operating theatre and had drainage of their small purulent pericardial effusion by left thoracotomy, and also underwent a laparotomy with omental patch repair of the fistula, followed by culture-guided intravenous antibiotics. And in retrospect, the patient was a confirmed diagnosis of pyeoneuropericarditis. The patient had a 2-month follow-up in which they were clinically stable with no features of constrictive physiology on history exam or echocardiography, and at 10 months with the surgeons had no recurrence of the gastropericardial fistula. So taking away from this case, we now understand that gastropericardial fistulae are a rare complication of gastrointestinal surgery and can cause pyeoneuropericardium. And management mandates urgent source control with adequate and swift pericardial drainage, intravenous antibiotics, and repair of any underlying anatomical deficits.
Thank you very much, Dr. Lee, for your very nice presentation. Perhaps I might just ask, your case presentation makes a great deal about the murmurs. You kind of, in your case report, so you propose that this is a very unique sort of murmur. What really makes this murmur different from the other reported murmurs of pneumopericardium?
Yep, I think that's a fantastic question, Dr. Sofian. So I think there were two previous murmurs associated with this condition. So the first one is the bruit de moulin, which was the continuous mill wheel sounding murmur. And then there was Hammondsine, which was the mediastinal crunching that we heard, whereas this murmur didn't seem to quite neatly fit into those two examples. So I think having the succussion splash in the inferior aspect of the heart and then the pneumopericardium aspect of it more in the superior aspect of the heart, we thought that this was the novel aspect.
Thank you. Over to the rest of the jury for any further questions.
Thank you, Dr. Lee, for another great case. I'm really curious to know how the mechanism of how the fistula forms. If the surgeon is performing a abdominal surgery, you've got a huge big diaphragm in between your abdominal organs and your heart. So how do you think pretty much what went wrong during the surgery to have caused this fistula? Is it a patient-related or surgery-related cause for the fistula that's happened? And my next question, you mentioned pneumopericardium. What was the what sort of bacterial infection was it? Was that was it related to the gut flora, or was it something different? And also the air, unlike the first case that we saw, you do have air in your stomach, and is this all coming from the stomach as such, or could there be connections coming from the lungs as well?
Dr. Canadian, thank you very much for those questions. So in answer to your first question, it was omitted due to the brevity of this presentation, but the key operative finding was of a chronic ulcer perforation through the stomach, through the diaphragm into the pericardium. It was from undiagnosed and unmanaged gastroesophageal reflux disease. Sorry, I can't quite recall the second question. Was it what was it again?
What was the organism in your
Yeah, so it was a polymicrobial infection. It grew Staphylococcus aureus, and it grew two commensals to the mouth, so Streptococcus salivarius and Streptococcus parasanguinus, and finally Candida albicans. And then in regards to the mechanism of how the gas got there, we believe it was multifactorial. The two biggest factors being, firstly, 100% the GI tract and there's a degree of aerophagia that occurs. We think that it was from the fistula, but also the streptococci are anaerobes, and these were locules of gas that were forming within the pericardial sac.
Okay, thank you very much.
Does anyone else have any further questions? Otherwise,
I would have a few questions. Did you see any signs of tamponade?
Thank you, Professor Achenbach, for that question. Clinically we had no signs of tamponade, so he didn't fulfill any criteria from Beck's triad. And on serial imaging and follow-up, he did not either.
Can you go back to the imaging that showed the fistula? I just would like to see it a little bit more clearly, because it's super difficult to see these small.
Yes, sorry. Yes.
So here's and you're rather certain that there's no artifact that causes this. And
regarding the fistula, no. It was also confirmed on the operative findings.
So basically, the fluid in the pericardium then was gastric fluid. Is that what you assume?
It was, we don't believe it was purely gastric fluid because 200, so they found a small volume of purulent fluid within the pericardial sac. So we did not believe that it was purely from gastric contents.
You put a lot of emphasis on the auscultatory findings. Did they change depending on the position of the patient? I was absolutely amazed by your explanations of the auscultation, because at least here in Germany, nobody auscultates that thoroughly. But obviously you did. But since, you speculate that this has something to do with the mechanisms and what is going on in the pericardium, these things I would expect to change substantially, whether the patient is sitting or lying. So I was just wondering whether your fine auscultatory diagnosis would change depending on the patient's position.
The recording was only taken when the patient was sitting upright. And these findings were more audible when the patient was leaning forward. Those two things were evident. But we didn't really appreciate the murmur as much when the patient was lying down.
Out of my own experience, I can say that I can, share, and you all know it's terrifically difficult to record auscultation findings. What equipment did you use to record these very nice heart sounds?
My colleague, it wasn't the Leaming stethoscope. It was one of the other competitor models. I'll have to ask him for it.
It was a brand over-the-counter electronic stethoscope. Huh?
Yes, it wasn't. Yes.
Okay, thank you. Fantastic recordings. Thanks a lot.
Professor Akasaka, do you have any more questions?
Yes, one question. You said congratulations, wonderful presentation, and you said there are several bacteria and fungal infection at the same time, right?
Yes.
Yeah, but it might be very difficult for me to understand why the fungus infection was happen in this condition, because there are risk of the bacterial infection. There are aerobic and anaerobic bacteria may cause these conditions, but at the same time you find fungal infection, right?
Yes. Thank you, Professor Akasaka, for that question. So we believe that there were three factors that may have influenced the presence of Candida on the fluid MCS, or the microscopy culture and sensitivities. Well, firstly, there was an anatomical defect, and we know that with from malignant causes and other sort of perforations of the GI tract, you can get Candida grown in culture fluid samples. But also the patient was on leflunomide, and their diabetes may have caused a degree of functional immune dysregulation that caused the Candida to be present in the microscopy in the culture. And beyond that, we don't have.
From the first, do you speculate the fungal infection in this condition? If I see this condition, right, I speculate the bacterial infection and antibiotics try to inject first, right?
But Professor, I entirely agree.
Yeah, right. Okay.
Yes.
Thank you.
Thank you, everybody. Thank you all the finalists for their fantastic presentation. Thank you to jury members, Professor Stephen Achenbach, Professor Takashi Akasaka, Dr. Vijaya Lakshmi Kunadian, and I would like sorry?
Thanks
I was thinking myself. Of course. So the results will be announced after the session when it's being played, I understand. And with that, I would like to thank everybody for their presentations. If I could ask the jury members to line, we can discuss the. Thank you very much.